Thanks very much for your time today, Rhonda. And this is the first in a series of discussions with members about private practice. Many people have indicated interest in starting a private practice and want to know how to go about doing that. So today's conversation is really about starting to get a sort of sense from people of how that might work in many, many different ways. I wondered if it would be okay for us just to talk quite informally about this for the next, maybe 45 minutes or so, and just really kind of give people a really a broad understanding of what it means to be in private practice and how you came to it, and what the, maybe later on we'll talk about what the pitfalls might be or the traps for beginners, that sort of thing. Mm-hmm. So I will just maybe ask you to think about where you started off in your nursing career, or how you started off in the field at all, and maybe you could just tell us all a bit about that and just a bit about who you are and your background in nursing.
Look, thanks, Claire. I think it's really a great opportunity to share. I'm not sure we do this very often, actually, share some of our stories around how we got into private practice. And many of us work fairly much in isolation, actually, and have done for a long time. And so it's really exciting that there's a bit of momentum gathering around nurses in private practice. I started my nursing 100 years ago in general nursing in the hospital setting, and knew then that that wasn't quite where I felt I fitted. I felt I wanted to have more of the human side of nursing, the humanistic side, the relational side of nursing, and eventually found mental health along the journey of my career, and had worked in a number of community settings over a long time, in mental health, adult and child psychiatry, in drug and alcohol field, and in community health. And it was in those areas that I really found my passion for wanting to contribute in a different way. And I thought a long time ago I should have done psychology. And when I looked at the training when I was in my 40s, I thought it would just take me too long. And here I am still in private practice, and I'm kind of pushing over 60 now. So I'm thinking maybe I should have done psychology in the first place, because I think the journey might have been easier, and I might talk a bit about that as I go along today. Questions. But I went into private practice in 1993, and it was really early, actually, for nurses in private practice, and I didn't know very many. And I initially hooked up with a friend of mine after some years in community health, and Marilyn was also a community health nurse, not a mental health nurse, but a community health nurse. And we thought maybe we would give it a go. But boy, what a steep learning curve that was. And I've moved in and out of private practice since then, but I've spent probably about 20 years in private practice now, all up. So I've been around for a while.
Yeah, wonderful. That's in nursing terms, you really were a pioneer.
I think so, yes. As I said, there weren't many, or I didn't know of many. There may well have been other nurses out there. It's not uncommon for nurses to end up doing psychology, actually. I've also got friends who have done psychology and then went on and did nursing. So it's not surprising, actually, that we probably have got some intersections in terms of the interests that we have. But, those people who did psychology went on and became psychologists, not nurses in private practice. And I think there's something quite unique about us as mental health nurses in particular in private practice.
It's definitely not the way that we're taught to think about nursing. We're sort of taught to think about nursing as slotting into the public health sector or the private health sector or the community. And so to think about us as having the temerity to start our own private practice, that's quite a big step for us, isn't it?
Yeah, absolutely. I mean, to step outside of that system, I suppose, either private or public system, it's quite. I think I agree with you. I think it is. It's quite a risk but it's quite exciting as well. I mean, I think community health probably helped me with that transition. Had I not gone into community health, I may not have seen the opportunity. But when I was working in community health, my role was particularly with youth and women. And it's actually my mental health skills that I was using more than my general nursing skills, actually. There was a lot of need for support, and a lot of what I did was supportive counselling by default, in a way, because people didn't have access to resources in the centres that I worked in. It was in the early days of community health, in the good old days when, you know, community health was very grassroots, and I was actually the only health practitioner in the first clinic I worked in. There was no other health people. I found myself doing everything from community development to setting up programs, health education, health promotion, but
Really?
counselling, you know, supporting people who were distressed. And it's probably helped me to gain confidence in my own abilities, and to recognise what it is that we learn as community, as mental health nurses, in terms of relational experience and counselling and support, and assessment, and being able to understand a much broader perspective of people's health and well-being. I think there's something really unique about mental health nurses.
I think I completely agree with you on that. And I think, and this is why this conversation that we're having now is so important, because so often we find that people don't, as nurses, we don't necessarily see or appreciate our breadth of our skill range, and our depths as well. Sometimes, you know, we don't, it's like we're blind to our own goodness, our own, you know, expansiveness of skills, and and the system, of course, shapes that idea too, that we should just be kind of grateful for any crumbs off the table and just be good little girls and not, you know, cause too many demands on the system, you know. So I think having that broad base of skills that you're describing and sort of building up your confidence in yourself through that process, I think that's a really important facet. I don't know what you think, but I think that's important for anyone thinking of starting a business of their own, that finding some way to really kind of own what you know and develop what you know.
Well, it's so important what you're saying, Claire, because I think we limit ourselves. I think there's a sense that we don't really own. You know, it's taken us a long time, even in mental health, where I think we were probably leaders, actually, in kind of thinking broader about the contribution nurses make. And probably we're respected to an extent in mental health in a way we weren't in general nursing, for our skill and contribution, and a more equitable contribution across the team, in a sense. And again, I probably learnt that in child and adolescent psychiatry in particular, when I was working at Travancore back in the day, at the Midwifery Centre at Travancore. And then I worked at the Midwifery Centre, and I think we probably had a bit more of a sense of that, but still we were constrained by our own expectations of what our role was about and who we were, and perhaps not owning all of the skills you learn in nursing. But of course, that also was that other people didn't recognise that either. And, you know, it's been really hard to fight for recognition. And we'll get to this in our conversation today, but as a private practitioner, as a nurse, trying to sell that idea that we have, you know, a whole range of skills and capabilities and capacities, and to get us, you know, out there in terms of the visibility around this. I think psychology certainly has they have a monopoly in this kind of way, and because they're so clinically focused, and particularly early on clinical psychology, the medical profession, who are actually our main referrers mostly, actually go to that clinical model because they actually somehow understand it. So I think we've got to work harder at both accepting our skills, and also letting other people know what we actually are capable of.
Yeah, almost learning not to fear our own, I'll use the word greatness, as in terms of the breadth of who we are, and not being hesitant I mean, it was really interesting last year when I did that survey of members. So many of our members have multiple master's degrees in psychotherapy, and yet they're still kind of hesitant to call themselves psychotherapists, and they're still reluctant to step into their own private practice, despite this obviously vast knowledge and skill and experience. And I'm really interested in us seeing how we can change that, shift that perception. That's really one of the missions of our special interest group, is to sort of empower people who are in this field to want more than what the system currently gives them.
Absolutely. Look, and I'll put my hand up. I'm just as reluctant to put myself in that category, which is ironic given that I've been working in this field for a long time. But I think for me, initially, it was trying to offer something counter to what was actually being offered out there already. And I guess, being trained in psychiatric nursing in the day, when I was much more comprehensive, and we went into a lot of psychoanalysis, and then I did family therapy training, and there was a lot of analysis of family. And I think I was trying to position myself as not a pathologizing kind of in that sense of, because I think there was, for a long time, I think it's changed absolutely. In 2022, counselling, therapy, people in therapy is very accepted now. But I think when I started in 93, people were still reluctant to talk about it. People had the kind of Freudian kind of idea of psychoanalysis, and nothing wrong with psychoanalysis, but it's not my style. And I think I wanted to set myself apart from psychology, and to say that I was a psychotherapist, somehow I didn't want to be, perhaps I didn't want to be seen to be a fraud. I didn't want to be seen to be masquerading as a psychologist when I'm actually not. But I think it was my pride in being a nurse and being a mental health nurse and a community health nurse, and that I offered something different. And people came to me because they didn't have good experiences in psychotherapy. And so I think, I'm as guilty as everybody else of not claiming that. You've really challenged me around that, Claire, just recently. Think about what actually am I? I always call myself a counsellor or a family therapist, and I'm definitely a family therapist, no doubt about that. So I can use the therapist term in terms of family therapy, but I don't use it in terms of psychotherapy. Interesting. Maybe that's a debate for us as we go forward.
Yeah, it's so interesting. And I mean, I think the other wild card in therapy itself has changed so much in the last, do I call myself a neuropsychotherapist these days, or or a neuroimmuno endocrino psychotherapist because I'm a nurse? Like, what do I call myself? And our group last year, as you know, spent quite a lot of time. There was a working party that we sort of sat around for a while and sort of talked about, well, who are we as psychotherapists and who do we want to be? And from that, we created 7 principles of practice and stuff, which, I'm sure will change and evolve over time. But I think what we're doing now, this is a really healthy discussion, because whoever we are as psychotherapists, it's always going to change and evolve over time anyway, as we change and learn and grow and, learn other things. And, so I think what we call ourselves something that's not too fancy or elevated in some ways, because if we say I'm an expert on things, that leads us down the path of the old, some of the old forms of psychotherapy where there was this sort of expert, do everything. And we, as nurses, we don't kind of relate to that old so well. But I think what we should say is that we're really competent at whatever we do. I think that's what we should be proud of and really stepping into. You are, as a psychotherapist, I know, Rhonda, very, very competent. So, that's something to kind of hold onto, I think, with pride.
Yes, I absolutely agree with you. And for me, I do want to hang on to the mental health nurse in me. I think because that's where I really found my place in nursing, in kind of traditional settings. And what I'd been looking for was finally realised I didn't have to step outside of nursing to actually become a psychotherapist. You know, I could actually do that with my nursing, and I always lead my conversations with new clients with, this is who I am, this is my background, this is why I think I've got, you know, a broad range of strategies and interventions that I can work with you with, is because of my nursing. And I always declare it because sometimes it gives people some comfort as well, because they trust nurses, there's no doubt about that, so using it to engage. But I want people to know that I'm offering something different, but I'm actually offering it from a really experienced professional base training.
Yeah.
So I don't want to lose. So I don't know how we kind of
And
that
you know,
psychotherapy.
that's right. And even in organisations, like the last role I had in a hospital, I was a nurse therapist, but that never really sat well with me or with the people around me. They were very confused, and sometimes doctors would write referrals into the programs that I was running and say, call me a psychologist, and I'd have to go back to them and say, no, I'm not a psychologist. You know, it can cause a lot of confusion. Yeah, and so I pretty much nowadays identify as a psychotherapist who's also a nurse.
Yes, that's it.
You know,
That's a way. So you start coming at it from that angle. And actually, when I was just talking that through, then Claire, I was thinking, am I still actually justifying? Am I still somehow, you know, after 20 years in private practice and over 40 years in nursing, am I still actually trying to justify who I am? So I just think that's really interesting as we're talking and just, you know, saying it out loud, because I don't have these conversations with people very often.
Yeah. Well, it's one I hope will, over the next few years, we as a group of mental health nurses will be talking about more often, because we need to refine our thinking, I think, and really own who we are and what we are, and own the development of that as well. And one of the things I wanted to ask you, I've sort of got a bit of an entrepreneurial lens with this discussion as well, because I know that in the entrepreneurial world, sometimes people start their own private business, not because they've always wanted to do it, but because they're running away from something in the system that doesn't suit them. And I heard a few, maybe I heard some of that in what you were saying, but I wondered if there were specific things that you had decided for yourself that you weren't comfortable with anymore, or was it just really that you wanted to start your own, have some more autonomy, or what was it that, were you moving towards something, or were you moving away from something, or a bit of both?
It was pretty clear for me at the time. I was in community health from 1980. Actually, it was 97. Sorry, I went into private practice, not 93. So I went from working in child and adolescent psychiatry into community health, and it was in the time of the Kennett era in Victoria. For those who know Victoria, where it was really decimated, the kind of community services, and community health was absolutely decimated under the way that they were kind of framing the way that the healthcare system would change. And I felt really disillusioned because I'd finally found my place in community health, because it meant I could bring my mental health self into the community, and I could work reasonably autonomously, but I still had a team. I was working with an allied health team rather than a nursing team, and I found that really enriching and rewarding. But when it started to, there was pressure on nurses. In fact, we had to fight for our, I kind of went out of mental health where we had to fight for our recognition in nursing to community health, where I had to fight even harder, because even within our own profession, community health nursing somehow was seen as a poor cousin to the critical care nurses. And so I'd finally kind of, you know, found that. And when the policies were heading back in the direction of making nurses more clinical, that we would become, basically we go back to doing wounds and dressings in community health. That's not what I signed up for. You know, absolutely not what I signed up for. And the essence of community health, which was very grassroots community, a lot of connection with community, a lot of the stuff that we did that was building people's health and well-being in a different way, and a more sustainable way was being taken away from us. And so it made me question what was the next step for me and where did I want to head. And I'm not sure. I think it was my friend Marilyn. I think we talked about all of the things that we offered and all the training we'd done, around, I trained as a key force, which is like a Reiki practitioner. Around that time, I was also training as a Bowen technique therapist, which is a maneuvering of muscles and ligaments, because I wanted to offer a more holistic care for the people I was working with. And so it made sense that actually I could be doing that myself. I don't have to be working for a public, and I think probably, I'd got to the point where maybe I'd done all I needed or could do professionally at that level. Maybe I was a bit burnt out, working, worked a lot with violence and, substance abuse and lots of really challenging areas of work in community health, and perhaps I was ready for a change. But for me, it was really, I think, it was the progress of what I'd been building to for a long time. Family therapy came later. It was something I was going to do much earlier and didn't get around to. That came later for me. But I think I finally realised that I could stand in my own professional self and offer something to people in a private practice. I was never money driven, Claire, and I still am not, because I'm probably not the most profitable, successful business person, but I've loved what I've done. And I think when you come into private practice as a nurse, psychotherapist, or whatever aspect of private practice you want to take up, there are challenges around funding and money and all of that. And some people are better at attracting more of that than I am, but it's never been the driver for me. So it was really about being able to provide a much more holistic service and being in charge of that myself, and not relying on, government funding to determine what I'd be doing.
Yes, and it's interesting. Later, we're going to have a discussion with other people in private practice, and some people have their business set up fully on government funding, but I'm like you, Rhonda. I've never found government funding to be consistent or reliable because it's so politicised these days that it changes with the wind. Even things like NDIS that some people have been involved with, the way that they've ripped the funding out of that in the last few years, it's not a very reliable or stable form of income for anyone's private practice. So although some people have done really well from it because they've figured out, and we will be talking to others later about that, there are certain people who've managed to work the system in a way that it is okay in terms of making a living.
Absolutely. And I work with nurses who I supervise who are doing that very successfully. But there's a catch to that, Claire, and that's the administration that's required to utilise that funding. And so perhaps that's another thing I was actually escaping from, was the bureaucratic nonsense that one had to go through in order to provide the services. I was very frustrated in the public system, where we spent a lot of time justifying what we were doing, which could have been used actually doing more of the work and more of the care and more of the support. And so I think, my understanding from my colleagues and my friends who do access that funding, there's quite a lot of paperwork, there's a lot of reporting, it changes, the rules are hard to navigate.
The rules are changing, the buckets of money change, the whole system changes its mind.
So I think people who are more administratively minded and better at that sort of, that they've got really good skills in that, I think they're the ones who probably find that more doable and more achievable. And so, yes, there is definitely opportunities. And, I think the other thing for me, Claire, initially was accreditation. And one of the things that I've struggled with for a long time in nursing is that we seem to bend over backwards multiple times and jump through hoops and do somersaults and do cartwheels. And we have to, even in education, I worked in academia for a long time, we put our students through an enormous amount of rigour to get them to the other side. And I think it's partly because of that identity that nurses have. So I found accreditation quite arduous initially, and I didn't seem to fit into the accreditation process somehow. And maybe it's just also my lack of wanting to conform to, particular rules, I suppose. But initially I found it quite a stretch to apply for accreditation. And in order to access funding, you do have to have accreditation, at least that's my understanding. I think you still do. So I haven't quite gone down that path, perhaps to my detriment, but I haven't quite gone down that path of seeking accreditation.
So do you mean business accreditation?
No, I mean nursing, mental health nursing.
Oh, mental health nursing, like the credentialing process.
Yeah.
Yeah. I mean, yeah, that's a whole nother topic for discussion. But yeah, I mean, the most important, I think, credentialing is certainly very important in some ways. But you've trained as a family therapist, and in that process, for example, your work would have been closely watched and supervised by a reflective team who would have given you feedback and guidance about your work and microscopically looked at you working with actual families, real families in the real world. So obviously you've got skills there, even if you haven't formally gone through the credentialing process with the college. But we will, next year, we'll be offering this, one of the courses that we're offering next year will be this grad cert in trauma-informed psychotherapy practice, and that will be, I'm told, that could lead to part of, pathway 2 for credentialing for some people and stuff. And, I think there's still a lot of room for us to investigate different things that make us feel, some people belong to PACFA and have membership of PACFA, and that they regard that, or the ACA, or, so there's different ways of being credentialed as well. Some people get their business credentialed through having an ISO certification process. There's lots of ways of doing that. The question I would really ask is, do clients come back after the first session, and are they happy with the services that you are providing? And my guess is, with all these years of being in private practice, that the answer to that would be yes. So that's another form of like a stamp saying, oh, you're doing a good job.
Yes, I mean, I was thinking that in terms of the question you posed to us about, how do you measure success, I suppose. So how do you measure the quality of service that you provide? And I think you're right. There are other ways of getting that feedback about whether what you're offering is at a standard that is acceptable to the community. And for me, that's probably more important, actually, than recognition by my... I know I might stand out alone on that sometimes, but for me, that's far more important to me, actually, than an organisation or a professional body or another person, another professional giving me that feedback. It's actually what the community give me and what they say about what I do. And time and time again, my clients say to me, I've tried counselling before and didn't quite work, all that talking stuff. And I would just talk and then I would go and nothing would change. And when I see you, we do things, I learn new skills and I learn how to actually do things differently, and you're very practical. And I think that's nursing. I think that's what we are as nurses. We're very practical,
Yes.
Of course, we all practice differently. And of course, there are times also when I allow a lot of room for people to talk. But when I get that feedback, I go, actually, yes, I've got a contribution to make here. And that I don't see people usually in the longer term. Although that's changing, I think this time around in private practice, I seem to have clients that are coming back to me for 2 or 3 years, which is very different to how I used to practice. Perhaps that's a sign of the times, a sign of what people feel they need now. But yeah, I think that's really interesting about credentialing and what it actually means. And I think there is a need for us as psychotherapist nurses to actually have a process that makes sense to us in that credentialing process. And so it'll be interesting to see the influences that might come to bear on that into the future. you know, and I guess seeing us as our own unique part of mental health nursing in itself.
Yes, I think we'll be working toward having a sort of an additional type of credentialing that will be available to people that have demonstrated long-term psychotherapy skills and practice. And, you know, because it's part of how we, so that the credentialing at the moment is more of a generic, you know, overall experience and skills, whereas what we're wanting to, and we're still at the very early stages of discussing this with the college, but we do want to have more focus on psychotherapy as a discrete skill set that can be given recognition in its own right by the college. So I wanted to ask you, you know, when you started off, what it was like in terms of, was it a bumpy ride from a sort of, were you sort of sleeplessly awake at night worrying about earning enough income, or was that a fairly smooth transition? Were there periods of abundance of just making it workable as a business, and periods where it was less abundant? What were your experiences in that regard?
I was fairly lucky because I had, you know, I finally worked somewhere long enough to get long service leave, and I took that as a payout at the end of my community health time. So I had a buffer, if you like. I had a time where I could focus on setting up my business and not feel that I had to be reliant on an income straight away, because there are lots of considerations when you start your own business. You know, where are you going to practice? Are you going to be, you know, paying rent? You know, how much rent are you going to be paying? You're going to be sharing with other people. Are you going to go into a practice where you've got other like-minded practitioners, so you've got that support? You've got to put money into advertising. You've got to put money into, these days, I mean, back then we didn't have things like websites, but gee, that's weird, isn't it? 1997 doesn't seem that long ago, but it wasn't my first priority in 1997. But you know, now there's websites and people have blogs, and you've got to put money in to create a business before you even get going. And then there's all your professional, you know, organisations and associations that you've got to be part of, and your professional development and your supervision. So it's not as straightforward as just going out and hanging up a shingle and saying, here I am. So I spent probably 3 or 4 months in that period looking for where I'd work, setting up practice. And the bumpy road was that it was really hard to find a place that I actually felt I could work in. I'm very sensitive to energy, and I pride myself in setting up an environment in my practice that is welcoming, but it's also therapeutic. And so I found it really hard to find a space that I could afford, where I could feel that I could work and that people would feel welcomed and feel held in that space. So it took several goes at that over time. And I initially set up my practice with my friend who I was talking about, but for a number of reasons it didn't quite work. We were perhaps similar in lots of ways, but not necessarily in the way that we thought about establishing the practice. And then you've got to sort of set up your referral base, and all of those things take time. And so the fantastic thing about being nurses is we can earn an income anytime, anywhere. And so I spent a lot of time supplementing my desire to be a private practitioner with bank nursing, and did a lot of, kept me in touch with nursing. It kept me in touch with my skills. It meant that I could earn an income and keep supporting my practice. And so I did that for years. I did clinical teaching, I did tutoring, I did whatever I needed to do in order to create the dream that I wanted. I don't do that anymore because it does split your energy, and I was wondering why I was still doing night shifts, and here I'd set up my private practice to be autonomous on my own. But it does take time, and I didn't probably have quite as many of the resources, the networks, as I would have liked, because I moved locations. So I'd moved from one region to another, and so I kind of lost some of those connections where I thought I'd get referrals from. And because I already said I'm not that money driven, I suppose, I was happy not raking in the money initially. And I think one of the challenges is actually, how do you set your price?
Yes.
How do we, yeah.
I do think it's one of the hardest things that people wrestle with in their own business.
Absolutely. Look,
And
the
we
ACA,
benchmark against,
yeah.
and often I think when we start in business, we often think, oh, I'll just be the cheapest and then people will come to me.
Yeah.
And that's not a good strategy, but that's what many of us do to start with.
It is.
But it's not a sustainable strategy.
And then we undersell ourselves.
Yep.
And then that undersells the value of the work. The other thing, because I said that I was a Reiki practitioner, and also I was a practitioner in Bowen technique, I had more things to my bow, if you like. I had more strings in my bow than just psychotherapy, because I felt that, well, personally, I wanted to offer a much more holistic practice then, and I really enjoyed working with energy, and but I had to be really clear about my boundaries, and when I was a psychotherapist and when I was a Reiki therapist and when I was sometimes they morphed, but I had to be really clear. So it actually ended up being quite hard because I kept having to split between these different roles.
Oh, interesting.
Sense. Yeah. I mean, I still use a lot of that experience, but I don't practice in all of those areas now. And also each of those areas, particularly in Bowen technique and psychotherapy and nursing, I had to keep up my professional development. So eventually, something had to give. But that's how I initially set up. And so I was doing some relaxation classes. So I was trying to be really creative with what can I offer while I'm getting a reputation, while my credibility among professional colleagues, while I was getting clients, because eventually word of mouth is how, and I don't know about you, but that's what sustains my practice. It's
absolutely, yeah. I have a website now, but word of mouth is how I get, 99% of my referrals.
Yes, and so that's how you get going. You actually get a few clients. They feel happy. They start telling people. They tell their GP or they tell their, somebody in their family, and then that's how it gets going. And that for me is that's where the sustainability comes from. And so what you were saying before about, do people turn up? Do they come back after the first session? And yes, they do. And they then might even come back a couple of years later because they experienced something that was worthwhile. So it's in what you deliver. So yes,
Yeah.
I think I've gone way beyond the question you asked me, but there are a lot of things to think about coming into private practice.
There are a lot of things to think about, and it sounds like you're very creative and very resourceful in finding ways to give yourself the time to sort of find your feet in your private practice, and then work out over time what you could let go of, so that your energy wasn't, as you were saying, sort of split too many ways, because that can be a bit exhausting as well.
Yes. And look, when I initially started in private practice, I didn't have a counselling qualification beyond. And when I say that, I say that with a bit of tongue in cheek because I think we learn a lot. And I think the training that I certainly had back in the old days, we did a lot of group training. We did a lot of, we did a lot of psychoanalysis in our training for ourselves. And so I think we did actually get good counselling training, but it was never called that. Never actually, we were never trained as counsellors or therapists in that psychotherapy sense. We were trained as mental health nurses using the tools that come out of psychotherapy and psychoanalysis and counselling.
Yeah, they used to call it the therapeutic relationship. You used to have to put that on all the exams.
Yes.
Therapeutic relationship number one.
And you still do, Claire.
Yeah.
And I'm not sure that some of our younger nurses quite understand it because they don't get to practice it in their training until they get out and become, particularly in mental health. So initially I didn't have that, family therapy. When I did that training, it changed the way I got referrals and the way in which I was perceived in the private practice world in psychotherapy. So I think it is important to have those qualifications for the training and the experience and what you learn about yourself and what you learn about people and relationships and therapeutic relationships. But it's so important also in terms of the credibility, because it's what the wider world understands. They don't understand mental health nursing.
Yes.
They understand mental health nursing and family therapy.
Yes.
In that sense, or whatever else it is, trauma therapy, or
mental health nursing and couples work, or mental health nursing and trauma work, or whatever the thing is. And it's something that I often, when people ask me, what do I do to start a private practice, I said the first thing is, I think, to figure out, do you want to have you need some sort of specialty or something that you could be recognised as having expertise in. I think that's really important in any private practice.
Yes, and it gives people a certain security in that as well. I mean, I continue to retrain, or not retrain, but train more and gain more and more skills. I'm sure you do too, Claire. And I think that's the nature of nursing anyway. Always got to be doing more. But in private practice, now I've actually trained as a couples therapist as well. And so where I am now to where I was when I started in 97 is very different.
Yes.
In terms of, I suppose, what I have to put out there in terms of this is what I do. And so GPs, GPs are a terrific source of referral, but gee, they're a hard group. They're a hard group to engage with. They're a hard group to get to listen to you because they're always busy. It's a hard, you've got to almost, I now work in a general practice. It's much better to work within, because then, although most of my referrals still come from outside the clinic, not actually in it, which is extraordinary. Occasionally I'll see a message on the messages going, does anyone know somebody who could do couples therapy? Hello, I'm here. But they understand, that for some reason GPs always want to know, what is it you do? So are you doing cognitive behavioural therapy? Are you doing schema therapy? Are you doing... So somehow for them that makes sense, because it's a framework, it's a formula. They get it. They know a little bit about it.
Yeah, it's something that they can not have to think about as to there's some sort of structure or framework for the person they're referring to. It's interesting because I don't get any of my referrals from GPs at all. So it's interesting. I get all of my referrals from word of mouth, but it's word of mouth from psychiatrists that know me.
Oh, that's interesting. Well, you work in a very specific field too, don't you, Claire?
Work with complex trauma and the somatic presentations of that as well. But I think what it is building relationships with whatever the sources of referrals are to our practices, that need to invest some time and energy in developing those referral sources. It's not as simple, you're right, with GPs of just bringing over morning tea anymore, because most of them haven't got time for morning tea. They're running. And so how do you get them to listen to you? Well, we have to find ways to talk to our referrers about things that they're interested in. So it's I think marketing is perhaps underdone by many of us.
Yes. And I think our expectations around that are probably a bit low. I think we have to raise that, because when you're marketing, and it comes back to what we started talking about, Claire, about the fraud. Do I really have what it takes, or am I just thinking I can do this, or can I actually do it? Because when you actually go out there and market, and some people are frightened by that word marketing, but when you go out there and try and build your reputation, you've got to stand up and say, this is what I do, this is who I am, these are what my skills are, these are the people that I actually like to work with, these are the sort of conditions that I think I work well with, these are the things that I'm not so interested in working with. So you've really got to show up and be confident in yourself, and be clear about what it is you do and don't want to do. When I went into private practice, I decided I didn't want to do crisis work, because I didn't want to do that anymore.
Yep.
And I put that out there. And so I don't do crisis, when I say crisis work, I don't see people.
You don't calls at 2 a.m. in the morning.
No, absolutely not. I'm not interested in doing that. There are other people who can do that, but I'm not going to do it. So you've got to be really clear about what it is you're offering and what you're not offering, and then finding a way to package that and to sell that and to speak about it in a way that convinces other people that you're the person for the job, in a sense. It's a bit like going for a job interview every time you sit down with somebody talking about your practice.
Absolutely. And do you have that as part of, do you have like a formal like terms and conditions or how you work that you get people to sign off on before they start? How do you?
Yeah, look, that's really interesting. I started out doing that when I started in private practice because I think it gave me a sense of confidence. And I think as nurses, we're very exposed to risk in all sorts of ways, and risk to us as practitioners. And so I think it gave me a sense of security, but I actually do a lot of that verbally now.
Right.
And it hasn't come back to haunt me, but it might. I mean, I know my psychologist friends do it. They give out a very formal, and some of my nurse friends give out a very formal kind of thing and get people to sign. But I find that people respond. I mean, in my first session, I set up the terms and conditions, if you like. It's part of my my introduction. And, you know, are you okay with that? Do you think so? And then I record that. So whether or not you do or don't need it, I might regret that at some point down the track, because sometimes having that formal process and having that documentation can be helpful also with the person who's coming to see you, so they understand and they've got a reference to that, but you can also come back to that. And in the general practice that I'm working in at the moment, we've had a few, not with the allied team, the counselling team, but with some of the patients that see doctors. We've had some issues recently with some fairly bad behaviour, and so the practice is now thinking about what are they going to give people as well in terms and conditions. So it's come back as a conversation that I've had to think about in the last week or so, just the last week or so, about whether or not I should do something a bit more formal. I mean, I think while I might not have always had the confidence in my, you know, what it is I offered and you know, how come I'm out there doing this, I've always had a fair amount of confidence in my ability to read people and to de-escalate and to give people a safe space and to feel safe in that space. I've never had a client where I've actually been concerned or worried about behaviour. So whether that I've been lucky or whether that's because there is something about the way I present that holds people without actually having the document.
Yeah.
I think it's a discussion for us to have, though, Claire, as a broader.
Well, but I think you're making some really good points as well, that actually probably the most protective thing that we can do is to develop really good relationships with the people that we work with, really warm relationships. It doesn't always, but it mostly, that's the best protector that we can have. And I base that on my knowledge of what happens in the legal sphere when people get sued and things like that, that actually, and the number of complaints people make goes down dramatically when they feel seen and cared for, and that their issues are recognised by the person that they're talking to. So I think you're absolutely right. And I probably would invite people to think about formalising that as well in some way, just because we live in a crazy world now and all sorts of things. And one of the things that I'd invite people to think about if they're wanting to work as a psychotherapist in private practice is to think about what they could say about what psychotherapy doesn't do. Because some people come to psychotherapy hoping for a magic bullet. And so I think it's important for us to also make it clear that, for example, you know, we can't solve the problems and patterns of a lifetime in 2 sessions or less, or, you know, sort of have some kind of sense
of setting up expectation, I suppose, and being open and honest with people about what it can and can't be. I think that's important. I mean, I have, because I've been thinking about it this last week because it's come up in the practice, but some conversations we had earlier last year in our supervision group, just around, I was thinking about that again. Have I become a little bit too relaxed with that in a sense? And that maybe there's a somewhere in between. I must say the document that the clinic came up with was appalling, and I thought it actually would have escalated behaviour rather than actually quelled it. I think they were a little too abrupt with some of the ways they were describing the behaviours, and there were so many prescriptive behaviours. I don't think I want to go there as a patient. I'd be worried that I might muck up. So I gave them some feedback about that, about how you can present that how you can have expectations around behaviour and respect, and do that in a way that's actually warmer and
friendlier.
In 10 points instead of 2 pages of what you won't do. And also about remembering that, I think what you just said about what psychotherapy can and can't do, but it's also about what I can and can't offer you. And what you can expect from me is this. I'll be honest with you, and sometimes I'll gently try and confront, and if you're okay with that, and I'm not the expert, and sometimes you might like what I'm hearing, then you need to let me know, because we need to talk about it. So also what they expect from us, can expect from us in terms of our behaviour and our professionalism, and our respect for them as well.
Look, Rhonda, I've so appreciated having this conversation with you today, and we're coming close to the end of our time now. But I wondered if there's any last advice you might give people who are thinking about starting a private practice, if you've got some thoughts on that.
Just before I answer that, this is part of that. There was one thing I wanted to say. When I started practice in 1997, there was no such thing as a mental health care plan. And that has changed the landscape significantly in the last 5 years. Because everybody has access to that mental health care plan, regardless of their financial, which I have an issue with. I think it should be more accessible to those who can't afford rather than those who can afford. And so more and more people are seeking to use a mental health care plan to get a reduction in terms of fees and or be bulk billed. So I think that's changed the landscape for us as nurses, and that's where credentialing will be important, and that if people feel able to go down that path, then I think that's probably a good thing to do, is to think about whether you want to access that funding, and particularly around mental health care plan and Medicare. NDIS is a whole other ballgame, but there are lots of options out there. There's also lots of other areas where nurses can be really working, and getting a lot of referrals is around supervision. And I do both supervision and counselling for 2 reasons. One, supervision, obviously I can charge more, actually. I can charge for supervision because people understand it. They can also claim it back on tax, so I don't have to worry about, I'm not a psychologist, I don't have a Medicare number. But I also do it because it enriches me, and it gives me a balance in my practice. And so I think if you're thinking about stepping into the private practice world, think about supervision and get some supervision training so that you can offer supervision, because I think it offers us an income pathway, but it offers us much more professionally, and we can make a real contribution to the field. So I really enjoy that, and I provide supervision to nurses, teachers, family workers, crisis care workers.
Wow.
And so I think, and there's a really good association now for nurses. Well, it's an allied health clinical association organisation, but it's really helpful to be part of that organisation, because there's a real movement now in not only claiming space for psychotherapy and nursing, but also nurses as supervisors. So I'd encourage people to consider.
Is that AXA? Is that
yes, sorry, the Australian Clinical Supervision Association.
Yeah.
Which are making a lot of headroad into also ensuring that there's a framework and quality around supervision that's provided. So I think that that's something I'd advise people to think about. And that's something you can actually do at the beginning of your practice, because most of us now, particularly mental health nurses, have experienced supervision, and there's a lot of training that will give you the confidence to be able to provide supervision. So I think that's a really good thing.
Great idea.
And look, I reckon go for it. I mean, I think the more of us who are out there, and the more visible we are, and the more we offer in that space, the more we're going to be taken really seriously. And I think we already are, Claire. I think you and I and people who've been around a long time, we have built our networks and we have built our credibility. But it's also showing the face of nursing in this space. So I reckon go for it. It's really rewarding. It is hard work. Don't underestimate it. It is hard work, and it takes a lot of energy to keep generating your business because nobody else is doing it for you. You have to do it yourself. So you do have to put energy, I think, into that entrepreneurial side, the marketing, the building your reputation, getting out, talking to people. It's as important as seeing the clients because that's what will sustain you in the longer term. And the other advice I have is build your own support network. It's incredibly isolating. It's fabulous working autonomously, but it is isolating, and you've got to work much harder at those corridor conversations you have with your mates in the hospital setting. You've got to actually find those people and find them in coffee shops and meet with people and build up your own clinical supervision networks, both groups and individuals, so that you're supported. So I think that's about it. I'm sure I've gone completely off topic today. But
no, you haven't at all. And it's been absolutely wonderful listening to you today and conversing with you. And, I just think you're such a shining example of what we can do as nurses in terms of, having a great idea, getting it going, despite all the lumps and bumps on the way, and then really turning it into an incredible success and having something to be really proud of and a legacy to be proud of as time goes by. And in that, I can hear from what you've told me today, the growth that you've had as a therapist in that having your own practice as well. And so it's a sort of there's the benefit to the clients that you're working with. And also you yourself have grown as a result of having your own private practice. So, yeah.
Thank you, Claire, for those thoughts. I mean, I've been around for a while in healthcare generally. And funny, I'm only just starting to feel now that maybe I'm feeling good about myself in terms of who I am and what I provide, and I'm happy where I'm at, which is kind of extraordinary. When I think it's something about us as nurses, and sometimes it takes us a while to find our feet, but you can get there. Some people will get there much quicker than I did because I might have had a lot of self-doubts along the way and ended up toing and froing and going and teaching and all sorts of things. But I think you're right. I think personally I've grown enormously. I was always heading in this direction. It could have happened much earlier if I'd only had the confidence to do it. But if I knew people who were doing it, I might have felt more confident too. So it's so important to be sharing and talking, and I hope people do benefit a bit from what we're trying to present and do at this with this panel and at the conference later in the year.
Great. All right. I hope to see you at the conference, and in the meantime,
wouldn't that be wild? Actually going to a conference.
Anyway, we'll hope that you continue to inspire, and thank you so much for your wisdom today and your time. And I look forward to ongoing networking with you and to have you as part of the group of people I know as someone who's been really successful in her own right as an individual practitioner. So thanks very much, Rhonda.
Thanks so much, Claire.
Okay, bye for now.